This is really the state of the science in community living research, and my name is Sydney or Sid Pickern, and I'm the program manager here at the Community Living Policy Center or CLPC. And this session is a real treat. Next slide, please. This session is highlighted in yellow, so it's titled Community Living Research. What do we know and what do we need to learn? And it's part of a series. So please also join us for our final session next Tuesday, where we will present the findings from our community living policy stakeholder roundtables last fall. We will also be joined by special guest Allison Barkoff, the principal deputy administrator at ACL. So definitely tune in for that. And the recordings and any relevant materials will also be available on our website at communitylivingpolicy.org. Next slide, please. So before I introduce our moderator and panelists, I just wanted to go over a few access items. First, to view the ASL interpreter, please click the interpretation button on the bottom of your screen. A separate window will open that should allow you to view the interpreter. And for real-time captioning, please click the closed caption button on the bottom of your screen as well. Just to note, this is a round-robin session where the moderator will ask a set of 4 questions to our panelists. The audience mics will be on mute, but if you have questions, we encourage you to please put them in the chat, and hopefully we'll have some time at the end to answer them. Additionally, we will also be pasting 2 survey links in the chat, and one is a series satisfaction survey, and the other is a survey seeking input from all of you on community living policy priorities for the future. So please fill those out if you can. We really appreciate the feedback. And also, please feel free to post your community living research priorities in the chat as well. Next slide, please. So finally, this is a disclaimer. This series is being hosted by the Community Living Policy Center, and we are fortunate to receive support from NIDLR, which is the National Institute for Disability, Independent Living, and Rehabilitation Research within the Administration for Community Living. And the perspectives discussed during this series are of the speakers themselves and don't necessarily represent those of NIDLR or the federal government. And with that, let's go ahead and introduce our moderator and panelists. So we have joining us today, John Tschida. He'll be the moderator. He's the executive director of the Association of University Centers on Disabilities, or AUCD. He has spent more than 20 years using data and research to drive policy change and service development for individuals with disabilities. And before joining AUCD, he was appointed as director of NIDLR at the U.S. Department of Health and Human Services. And next we have Silvia Yee, a senior staff attorney at the Disability Rights Education and Defense Fund, or DREDF. Her work includes projects to increase accessibility and disability awareness in the delivery of healthcare services, including policy advocacy and impact litigation. Ms. Yee maintains interests in healthcare reform, international disability rights, and the strengthening of cross-disability and cross-civil rights communities. Yee views healthcare as a civil right for people with disabilities, since they cannot practically achieve community integration without appropriate home and community-based care, including long-term services and supports. Next, we have Amy Hewitt, who has extensive background in the disability field. She has worked in various positions over the past 39 years to improve community inclusion and quality of life for children and adults with disabilities and their families. Her career began as a direct support professional, and she currently employs direct support professionals to support her brother-in-law who lives with autism, addiction, and chronic medical conditions. She is the director of the University of Minnesota's Institute on Community Integration and conducts research, evaluation, and demonstration projects about community services for children, youth, and adults with disabilities and the direct support workforce. Next, we have Ari Neiman. Ari is a visiting scholar at the Lurie Institute for Disability Policy. He is currently a PhD candidate in health policy at Harvard, where his research focuses on long-term services and supports disability employment and public opinion. Prior to that, Ari served as executive director of the Autistic Self-Advocacy Network from 2006 to 2016, and as one of President Obama's appointees to the National Council on Disability from 2010 to 2015. And last but certainly not least, we have Natalie Kean, who is the Director of Federal Health Advocacy at Justice and Aging, a national legal organization dedicated to fighting senior poverty. Natalie leads the health team's legislative and administrative advocacy in Washington, D.C., and works in coalition with partner organizations to ensure that older adults and people with disabilities have equitable and affordable access to healthcare and services that help them live at home and connected to their communities. I also want to say that all of these folks either identify as people with disabilities or have family members with disabilities, and it's really these lived experiences that are so crucial to the knowledge sharing and growth in this field. And I think especially in light of the fact that it's Olmsted's anniversary this week, we're just really pleased to have you all here. And with that, I am honored to turn it over to John Tschida, who will take us into our first question. Next slide, please.
Thanks, Sid, and thank you to Brandeis and the Lurie Center and the RRTC for hosting this important conversation. And the timing of today's discussion is especially fitting given this week's anniversary of the Supreme Court's Olmsted decision. Thank you to our panelists for joining us for this conversation as well. And why don't we jump right in? And Natalie, why don't we start with you with our first question? What do you view as the most needed or expanded research topic or area for community living policy research?
Thanks, John and Sid and everyone. It's great to be here. I'm Natalie, she, her pronouns. I'm a 40-year-old white woman with brown hair and glasses. I'm wearing a pink shirt. And I have a blue virtual background with Justice and Aging's logo in the corner. The most needed and expanded research that I think we need for community living policy is on unmet need. We don't know what we don't know. Who are the people that are outside of the HCBS systems completely, learning more about who they are and what are their barriers to access. And more specifically, in terms of unmet need, we know that waiting lists for home and community-based services are just a fraction of the people who are really needing HCBS. And this is especially true for older adults. Only 16 states have waiting lists for HCBS programs that serve older adults. And many people, especially people with limited income and resources, can't afford to wait and end up going into nursing facilities to get their basic needs met right away. I'm really excited about work that the Community Living Equity Center, a sister organization to CLPC, is going to be doing to drill down and understand this unmet need on a more granular level.
Thanks, Natalie. And I want to invite any of my fellow panelists to jump in and respond to anything that the panelists say if you want to do that. I'd love for this to be more of a dialogue than a scripted conversation. Amy, reactions or additional thoughts?
I guess I would have some additional thoughts. Of course, a lot of my work and research is around the workforce that supports people with disabilities to be able to live in the community. And these issues have existed for over 30 years. I've been researching the challenges for 30 years, and yet we find ourselves in the same exact and worsening position around being able to keep people who enter careers in supporting people with disabilities. And increasingly, I mean, not a day goes by where I don't hear a story about the horrible consequences of somebody who has a disability and can't find staff, and then they can't work, and then they can't get to where they need to go. And these issues are exacerbated by COVID-19. It made things much worse, but there's not a lot of research at all on what are the effective interventions to keep people in their jobs. There's a real focus on rates and on pass-throughs of really small wage increases, but there's hardly any research on organizational culture and employer culture. So people who self-direct their services, as well as organizations who deliver services, how they treat people who choose these jobs is such a critical factor. We know that it plays a big role in why they leave. So I see that as kind of a really important area. And then another one is in the area of outcome measurement. And if we still have so far to go in how we're measuring the outcomes that people experience from community living, and we really don't have a good way at all of comparing, especially some populations within the disability community to the general population. So we make a lot of policy decisions based solely on the people who are in the system and receiving services, and are on measures that are designed to look at the system and not as much at the individual person. So I see that as another really big priority area.
Hi, this is Ari Naaman. He, him pronouns. I'm a 35-year-old Jewish man wearing a black shirt and having a big, bushy, unkempt beard. I want to sort of build on the prior comments by saying that I think we have a really dire need to build out a broader body of research literature on the causal effects of HCBS expansion. I think back to my time as an advocate, and back when the Affordable Care Act was winding its way through Congress, one of the big frustrations that many disability rights groups had was that proposals to dramatically expand access to HCBS by making it a mandatory component of a mandatory Medicaid state plan service, or to otherwise grow the availability of HCBS, generally were not scored by the Congressional Budget Office as realizing any cost savings on the institutional side. And that has continued to be a real barrier to getting significant new HCBS funding through Congress. And I have to say, as frustrating as I find that, increasingly I've come to understand that there is a gap in the literature, that we really have not built out a clear understanding as to on what margin expanding HCBS impacts people. And let me be clear by what I mean by that. I think HCBS expansion is hugely important. It absolutely helps people, but in specific instances, it's not clear if it's going to help people by reducing the risk they're going to enter an institution or a nursing home, by improving their quality of life, which is also, a worthwhile objective, by reducing their unmet needs, or by increasing the likelihood that the many uncompensated family caregivers will be able to participate in the workforce and have better health outcomes as a result of getting access to some level of formal care provision. And there's sort of the beginnings of a literature, suggesting each of those causal effects. But if we want to be able to tell policymakers, particularly those policymakers who listen to entities like the Congressional Budget Office, that expanding HCBS is going to mean you're going to be spending less money on institutions and nursing homes, or it's going to mean that, for every person who receives HCBS, you're going to see this kind of workforce response in terms of a previously, a family caregiver who had previously dropped out of the labor force be able to re-enter the labor force. We need to produce some of that high quality causal literature. And we're still, I would say, regrettably at a relatively early stage in introducing some of the designs that would give us those rigorous causal estimates.
Silvia.
Hi, everyone. This is Silvia, and I'm a woman with short, graying, dark hair, tan skin, and I'm wearing a dark purple shirt. Typically, I would be wearing glasses as well, but my myopia makes me not have them on at the moment. And I just agree with everyone who's spoken. I think that the needs I've mentioned are absolutely accurate, and but I particularly want to address what Ari was saying, because I feel that very deeply as well. What I thought of as sort of the number one need for community living policy research, and one of the number one needs is having a complete picture of the lives of people with significant disabilities living in the community. There's the good, the bad, and the ugly. I do think there's still such a great lack of comprehension among those who don't need home and community-based services themselves, who don't know anyone who needs home and community-based services, and who lack any understanding of how likely home and community-based services use will be in their own future, assuming they get to live a reasonable length of time. And I think this is together, that this picture, it needs to be presented as so that everyone knows the economic impact on an entire family when a family member has home and community-based service needs. And I think this is where it ties in with what Ari is saying as well. This kind of, if you don't know the need, and then you also don't consider the huge vacuum that occurs in the economy when there are people who are not in the economy because they're taking care of a spouse or a child or a parent, that this just scores as nothing. That proposals that would increase community living, the potential for community living and home community-based services, ignore that, or the impact on Medicaid and other public services of having a true home and community-based service needs met. I think all this information needs to be presented together in conjunction with updated research, including the impact of COVID, on the differences between institutional care and community-based care for the physical and mental health of long-term services and support users. People need to understand the financial difference between the two options, and the payers and the kinds of payers that do and do not provide long-term services and supports. I also think we need a lot more sort of state cooperation and exchanges of information about community living practices and data. But again, this truth that no one, except maybe the 1%, is going to be able to avoid home and community-based needs and the facing that choice of wanting to live in the community and how do you do it. It just seems like it's the general public has avoided it for facing this for a long, long time. And the research, the numbers need to be there, and the packaging of it for the public to understand before it becomes an imperative.
So it sounds like we're all in agreement that we need a better understanding of the bigger picture. Ari spoke, I think, very well about better understanding the implications of HCBS expansion. Amy, you talked about the direct care workforce shortage in particular, and a need for more alignment on outcomes. Natalie mentioning unmet needs as well. So where's the opportunity in the next 5 years to advance policy, to advance practice in home and community-based services that will get us closer to an understanding?
You know, this is Ari. I'm incredibly excited about the regulations that CMS just proposed with respect to Medicaid access. You know, first, simply at a policy level, before getting into the research, the proposal to require that at least 80% of Medicaid funding for personal care, home health, and homemaker services go to direct compensation for workers is really groundbreaking. And it's particularly important because it gives us a tool to fight the growing encroachment of private equity, you know, which just has such a horrendous impact on everything it touches in the HCBS sector. But in addition to that, the regulation would also put in place standard reporting requirements with respect to direct care worker pay, with respect to waiting lists, including how they're administered, if they're really interest lists, or if they're assessing people for eligibility before they're placed on the list, and you know, really just giving us a much clearer sense as to how to compare each state's Medicaid HCBS program to other states in a way that I think is going to just really improve the quality and rigor of the research we can do in this space. So there are actually 10 days left for folks to comment on the Medicaid access rule, and I will just flag that there are folks, you know, in some bad actors who I think are fighting it tooth and nail. But I hope folks will weigh in and support what CMS is trying to do, because I think it'll lay the foundation, A, for good policy that'll help address the workforce crisis, but B, for a much more solid set of data to improve the quality of research we can do on HCBS.
Amy, you want to jump in?
I did. I just wanted to respond to some of Ari's comments. I think the intention of CMS's regulations or proposed rule setting are good, although I think there's lack of specificity around some issues, and the fact that the direct care workforce isn't defined. So people who are in supervisory roles aren't necessarily included in the language. So I think there's some clarity that needs to happen. I saw a couple of comments too around like, where did the 80% come from? And does that, if you think about businesses, just your regular businesses, or as researchers, the indirects that our organizations charge to the government, trying to expect overhead to be limited to 20%, I think is something we have to look at. And the omission of people in supervisory roles, in other really critical roles in organizations, delivering community services is an area of concern. So while I agree in principle, I think that there's a lot of specificity that we should be asking for in our comments to CMS.
All right.
So, you know, totally agree with Amy that there is a need for, further clarifying certain aspects of the proposal. I would note just a couple of things. In the NPRM, CMS indicates that the 80% number comes from really a compromise between what different states are already doing. That, some states have a 75% requirement, some states have a 90% requirement. There's some variation there. I think there is at present, and this is, I think, one of the things you're speaking to, Amy, a solicitation of comment on, who should count towards that 80%, whether it might make sense to expand that requirement to encompass not just personal care, home health, and homemaker services, but other areas, including many of the areas in which that are relevant to IDD services. And, whether the 80% number or a different number might make sense there, for less labor intensive service provision. But I think the bottom line, though, is we do need some kind of threshold. It's not unprecedented. CMS already applies essentially the same framework for thinking about insurers and limiting insurer overhead through the ACA's medical loss ratio requirement. So I think as we think about the fact that there is, a growing surge of interest from private equity and other actors that have not been altogether positive for the LTSS ecosystem. There's a lot of research showing the negative impact of private equity acquisition. In the nursing home context, I think we have every reason to believe it would be negative in the HCBS context too. We need some kind of threshold. We need some kind of requirement that's going to hold the line and say, no, you can't take 30% and put it towards administrative overhead and, profit. So, obviously there are points to clarify, fully recognize that, but I do hope CMS finalizes this rule, and I do hope they maintain that 80% requirement, because I think it's going to be a crucial bulwark against some of the things we're seeing coming down the pipeline in this field.
Natalie?
Yeah, we're really excited about certainly the goals and bold steps CMS is taking in this rulemaking. I think there is, room to comment. I'd like to see them do more, and really a principle around this that I think this rulemaking can advance is transparency, helping us understand what is happening in these waiver programs, and some of the measures that Ari was talking about on waiting lists, and then also, whether people are getting the hours provided that are authorized under their plan, can really help us understand these programs from state to state, help people navigate them. And then, one goal that CMS has said they have for these waiting list measurements is to make sure that states are actually enrolling people in all the slots that are authorized under their waivers. We see this in California, where there are more slots authorized than provided, and than people enrolled in the program. And, kind of tying back to Amy's point, like, we can't do this without also supporting the workforce and expanding the workforce. So, competitive wages, adequate wages are absolutely crucial to do that. So we do think it's time for action, and are certainly in support of the direction that CMS is taking.
Thanks, Natalie. Silvia, thoughts on the access rule or other opportunities you see in the next 5 years?
Yes, I think the access rule is a great step in the right direction. I've been thinking in terms of the next 5 years, specifically about trying to find out more about what different racial and ethnic groups need. to gain effective access to home and community-based services, and what entities can best meet those needs. Because I do think we are at a moment, and still are, though we need to press that harder, of being more aware of the kinds of barriers that rise that can be compounded when people have different identities, when people have disabilities and are people of color, or have other characteristics that evoke barriers to healthcare. And in terms of that, I was thinking, I spoke recently with a number of people who work with Disability Rights California, who are the protection and advocacy agency for California. And they have been working for a long time to advocate within the California system of 21 state-funded regional centers that provide services to people with developmental disabilities. And this is a set of the regional centers have been required for some time, historically required to provide public information on the dollar amounts that are spent on various racial ethnic groups. So it's a kind of detailed, well, it's not detailed enough at all, actually, but it at least provides some information, some relative information between racial and ethnic groups about the kind of spending that's done on developmental services, services for people with developmental disabilities. And that information has, for the last couple of decades, shown clear and wide disparities in service delivery. But the detail needed to take actionable steps is not necessarily there. And this makes me think of Amy's comments. A lot of it is in detail. I'm a little afraid that you have states that are going to take the access rule and run with it, and you have states that are going to resist all the way. And I think advocates really need to be prepared for that, and researchers as well. For example, once a need is assessed in the regional center system, is it officially unmet, or is it not unmet until a service provider is available and willing? That's not how we typically think of a met or met need, and yet that is part of how the information and the data is provided. Until a service provider is found, the need is apparently not considered unmet. What is the average length of time between need assessment and service delivery? How often do the services provided meet the intensity level prescribed by providers? So I'm raising this because I think a lot, this specific webinar is looking at how advocates and community leaders can guide researchers and what researchers needed. But I found myself thinking when I was talking to DRC that researchers equally could help inform public entities, advocates, and the public about the kind of data that needs to be collected and how it can be done. I think as advocates and as lawyers, sometimes in our negotiations with state entities, with public agencies, we run into this, it can't be done. It's just too hard. We don't have examples of it. What you're asking for is really difficult, and it runs into HIPAA. It runs into privacy concerns. The detail you want is just too much. As well, of course, I understand the concern with HIPAA. Sometimes it's an excuse, and sometimes a way to fight back this actual guidance on, well, you can provide things this way. You can de-identify your data in these regards. You can collate data or collect it over years. That kind of really concrete guidance can be useful for advocates to have in their pocket and to push back against agencies and other entities who just want to continue with the status quo. And I'm speaking as someone who has faced that kind of argument before, and who would love to have a tool that says, well, we know that there are various steps you can take to get effective data. And you don't need to just hold this in your own pocket. You can make it available in specific ways so we can get a more complete picture. And of people who are living in the community with disabilities.
Amy?
Thanks, John. And thanks, Sylvia. I just was, as you were talking, I was thinking about an area of work that I contemplate a lot. I don't have the answers, but they're all related to research and addressing some of the issues that you talked about. And one of them goes back to measure development. And I think states are looking at diversity, equity, inclusion, disparity, and they're trying to address it. But the measures that they use now, if they do any measurement around it at all, is service utilization and purchase of service. And to me, those are extremely shallow measures because, one, you're measuring the people who are in the system. So there was something that they wanted from the service system. There was a service that met their need or they thought was going to meet their need. And I think we need to really step back and think about the frameworks we use for community living, what community living means to individual people and to communities, both people with disabilities and people without disabilities, because the frameworks and the assumptions that we used to create the system, and the system we've created is beastly. We didn't start by asking our community members of color, from GLBTQ communities, from all various different diverse communities, what community living means to them and what they want. So in California, there's this huge disparity in purchase of services, and you can't even tell right now the differences between kids and adults and the differences around the kinds of services that are being used. So somebody might feel like their needs are really met and they're utilizing far less resource than somebody who's out of home, living out of home. That's one of the single biggest predictors of cost, is whether you're in a family home or out of a family home. So these are complex issues, and we try to go to find the one variable that's going to tell us the answer. And I think we have a lot of work to do in creating measures around these critical issues and defining, kind of stepping back and relooking at what do we mean by community living and what are the kinds of supports that people want, and not locking ourselves into, here's the service menu, that's it, take it or leave it. And then we wonder why 70% of people with intellectual disabilities who might need service aren't getting them. And it may be as simple as they don't want what's offered. They want and need something else, but we don't know that.
Sylvia and Amy, you both jumped into the next research question, which really is what research is most needed to reduce barriers to equitable community living. But Natalie, you wanted to piggyback on these comments as well.
Yeah, and I was gonna, I think it answers that question too about the barriers to equitable community living. You know, we particularly look at people with Alzheimer's and dementia, disease that disproportionately impacts Black and Latino older adults. And there's a pretty shocking statistic that at age 80, 75% of people with dementia are in nursing homes compared to 4% of the general population at that age. And so clearly our community-based systems are not built to meet that need. So that's a particular example of the types of inequities and barriers that we're seeing. And you know, what are the barriers? I think we need a lot more research and individualized research, and to Amy's point, to talk to people who are outside of the system and the general population too. And Silvia mentioned LGBTQ community. You know, there less, as older adults, less likely to have children and family to rely on to help them age in place. And we see compounding disparities for older Black women in particular. There's data showing that they're more likely to live alone as they age, and many of them have been caregivers or direct care workers and have lost wages and economic benefits throughout their lifetime, making them more likely to age in poverty and into poverty. And so really looking precisely at some of the barriers to keeping people with those compounded disparities in the community.
Ari, your thoughts on building a more equitable community living system and what research is most needed?
Well, I think there's a real challenge in getting a clear sense as to what interventions are going to be enhancing equity and how we can move the ball forward. Something that I've really been struggling with these last few years is how to think about the growing push towards more standardized forms of assessment, and in particular, the growing use of algorithms in order to allocate resources in LTSS. Because I have to say, I understand, and I'm very sympathetic to the concerns that are raised that standardization and algorithmic allocation reduces transparency and reduces flexibility. At the same time, I think we also know that flexibility that can be really valuable for keeping someone in the community is also often the conduit for really inequitable and often, frankly, racist or classist means of allocation of resources. And so I also have some sympathy for efforts to try and build more standardized modes of allocation, recognizing that some flexibility is going to be necessary. But I have a lot of sympathy for the idea that if we can try and take decisions about who gets what out of the hands of, say, a frontline social worker who's going to think, boy, that person or that family, they're a lot like me. I relate to them. I understand them. So I'm going to treat them better than this other family or this other person who I don't relate to as well. That may be a vehicle for improving racial equity. That may be a vehicle for in trying to address class disparities and access to these services. And I think we just genuinely don't know the answer. But when we think about equity, I really am very interested in seeing what future evaluations of the shift to more standardized assessment and algorithmic allocation in LTSS are going to show us, because it wouldn't shock me if some things that we're very concerned about right now, because of how they are experienced by the kinds of people who tend to be in our advocacy organizations, actually might, they might, we don't know, but they might be doing a good job or might play an important role in trying to reduce some of these race and class disparities.
Lots of others on equitable community living.
I was interested in chiming in on a couple of policy solutions that we're excited about that could start to address some of these issues. I think there are opportunities to chip away at institutional biases and the policies, and as we build a new system, I mean, that would be ideal, right? Starting with the people who need these services, being more expansive, especially focusing on people of color. But I think in the meantime, we have, opportunities to fix some of the biases and barriers that we know exist. One of them is, making sure that people can access home and community-based services promptly when the need arises, instead of having to wait. I think anyone who starts to navigate the system, once they find out that it exists, understands that it can be months and years before those services are provided. Making sure really that it's on par with nursing facility services, where you can go into a nursing facility today and the Medicaid paperwork will be worked out later. That is not the same for home and community-based services. And then also a big priority for us is ending Medicaid estate recovery. This is a hugely discriminatory policy that perpetuates intergenerational poverty and the racial wealth gap. We hear about people being afraid to access Medicaid because they know this policy exists, and especially communities of color who are used to programs that are supposed to help them actually punishing them. I think this is a huge barrier to their accessing these services right away when they need them. So those are a couple of things that we're really excited about on the policy front to address some of the inequities.
Silvia, go ahead.
I was just thinking, I'm sorry, John, that I leapt ahead to this other question. I'm thinking back again to that, like things you're excited about in the next 5 years, and the ubiquity of artificial intelligence and algorithms. I don't think it's going to take 5 years for that to happen. I think it will happen much sooner, and the excitement around the use of algorithms and artificial intelligence as tools in healthcare is very high right now. And I just think of that huge risk of these tools being trained being trained in the current world, in the situation we have right now, and we're in a current world where we really still don't know the full scope of all the inequities and the barriers to access to primary health care, much less to home and community-based services and community needs. I think going back again to, let's say, the access rules or Medicaid managed care rules and the requirements for representation, for stakeholder representation. I mean, I think that's great, but stakeholder representation can't be effective without a really, truly level playing field for community representatives who are receiving home and community-based services. And I think we still don't have that. How difficult it is to be an advocate and speaking for others and aware of the problem and still living with a complicated reality of being an HCBS user yourself. We need research that looks carefully at distinctions between home and community-based service users, and those distinctions can be from race and ethnicity to the particular vulnerabilities of LGBTQ plus individuals, which Natalie has mentioned, and also the distinctions between people who have been disabled for most or all of their lives and people who have only acquired a disability as older individuals. There are all these different ways in which community living, the ideal of it, the needs vary amongst populations, and to know those things and to train and embed those things in the algorithmic and AI tools we will use, I think is a huge challenge. It's an opportunity, but also a huge challenge over the next 5 years. And it brings me back again to what I was thinking of at the beginning, that we just still need the full picture of what it's like to live in the community as home and community-based users, what it's like for their families, for their support networks or the lack of it. We just need as full a picture as possible, so we have even a fighting chance of meeting the unbiased training needs of algorithms and artificial intelligence.
Ari, go ahead.
I want to wholeheartedly agree with everything Silvia just said on, the risks posed by AI, and the sort of the growing shift towards algorithmic allocation. I think the concerns with respect to biased training data are absolutely very valid. I also agree that this is coming regardless, right? And, as I think I said earlier, I think there is some potential for algorithms to actually be equity enhancing if they're done properly. And I think what's so challenging about this, what's frightening really, is I don't think our community is ready in terms of, building enough of a bench of advocates and researchers with a sophisticated understanding of these machine learning methods and the ways in which even sometimes more basic methods in machine learning are going to be brought to bear on these problems. So I think at some level there's just this dire need for us to almost start a boot camp for preparing advocates and disability policy researchers to kind of be introduced to machine learning AI methodology, because it is not going to be enough for us to say, this is really concerning, this is potentially scary. We're going to have to get in the weeds and say, hey, we think this model building process is wrong because of reasons A, B, and C, and we think you should modify it in, way 1, 2, and 3. And to do that, we have to bring technical expertise into the disability rights movement that we and a lot of other movements for social justice are still struggling to develop, because this is where the future is going, as Silvia was articulating so well.
I think we may need congressional staff and policymakers to attend that same boot camp to develop that foundational knowledge on machine learning, Ari.
Yeah.
Great point.
About it like it's religion, just a bolt from the blue, but these are understandable processes.
Before we go to our final question, and we do want to save a few minutes for any questions that our attendees may have. So please, if you do have a question, place that in the chat and we'll try to get to a couple of those. All right, sort of the not a magic bullet question, but I think this gets to prioritization. To our panel members, if you could have one study or a piece of data to advance community living policy, what would that be? And Amy, why don't we start with you?
Thanks, John, for starting with me. When I saw these questions, the very first one is so basic that came to my mind, but I'd be remiss not to share it. We still do not have the ability to accurately identify persons with intellectual and developmental disabilities in our public data sets that give us comparison groups to people with other types of disabilities and with people without disabilities. For example, the American Community Survey and others. So, that would be, if you force me to say one, that would probably be the one, though it's very granular and specific to persons with intellectual and developmental disabilities, and our community living center on persons with intellectual and developmental disabilities. But then I would go beyond, and Ari's much more sophisticated at thinking about this than me, but we have now these bifurcated data sets where we can look at Medicaid data, but then it's much harder to get at MCO data, and many states don't even put in their contracts access to that data, and you can't see the whole picture unless you have access to both, and unless you have variables that you can match. And so it's just made research really complicated when it's so hard to get your hands on some of that data because of the privacy or the contracts or agreements that MCOs have with states. Well, that's another one I thought of. So I violated the limitation to 1, sorry.
All right.
Amy, I'm gonna endeavor to violate the limitation of 1 by bouncing off of your great idea, because I 100% agree that the black box of what the heck is going on, when states move to Medicaid managed care is a huge problem. I mean, at the end of the day, this is still a public program, even if you're contracting out with an MCO to run it. And the fact that we have accepted this argument that, the data is proprietary, or we just don't have time to do it well, or, fill in the blank. And so we have almost no idea what's happening there is I think it's all but criminal. It's made, at this stage, 29% of LTSS spending in this country is in managed care, and we have almost no visibility on any of it. It's a huge problem. So, I'm going to +1 Amy's idea, and then, in the spirit of having my cake and eat it too, I will also say, I think we have no idea who the 6-question disability sequence used by the ACS and the CPS and all kinds of other federal population health surveys actually identifies. And it's really kind of a problem, because you see, folks just like try and map those functional impairment questions onto other categories. I've seen people, try and use the cognitive disability question in the ACS to look at the IDD population. I'm pretty sure there are very few people with IDD being picked up by that. You see people, use it, it's this kind of, I have a paper I'm working on right now where we're looking at the independent living and the self-care questions as sort of a proxy for LTSS need. But we don't really know if the people who are reporting those functional impairments are using LTSS or have LTSS needs. So insofar as there's an opportunity to take some of that survey data and link it with administrative claims data to just get some sense as to what are the service utilization patterns of the people the ACS and the CPS and the BRFIS and the NHIS are saying are disabled, what diagnoses do they have? Who the hell are these people anyway? That would be my 1, which is really 2 things. Thank you.
Thank you, Ari. Silvia, your thoughts?
Yes, thanks, John. And I'm a big cake eater, so it's very easy for me to. I was kind of hoping I could go fourth, and then if I was fourth, I could endorse all the 3 before me and still have a piece of cake left. But yes, I think everything that Amy and Ari has said is true, and what Ari has said makes me think of how long it has taken race and ethnicity advocates to fight for more granularity on the kinds of questions that are asked around race and ethnicity, and it's going to be a long process of fighting for better development, for more questions, for greater granularity. I at the risk of being sounding or being a little bird-like, I'm going to mention something I actually have not mentioned at all before, and the one study or area study that I'd really like to see is data that looks at the impact of receiving high-quality, community-based mental health treatment on outcomes such as obtaining and maintaining housing, economic stability, education, and employment for people with disabilities living in the community. I think it's really important to see where that kind of community-based mental health treatment is offered geographically, who gets that kind of treatment when it comes to race and ethnicity, age, home and community-based service needs, people with communication disabilities, people with developmental disabilities, and people with diverse sexual orientations and gender identities. I think it's that there are many people with disabilities who also have mental health disabilities and mental health needs, and it's an intersection that isn't raised as often as it could be in the community-based living space, and maybe just where I've been reading or where I'm looking, but I just think it's a really important juxtaposition that will really become more important given the trend towards just not having enough resources, not having enough treatment, and the kind of political trends as well, where we see always a casting of blame on people with mental health disabilities when it comes to gun violence and other things. There's a lot of rest on this, on understanding more and delivering community-based mental health treatment. And so I think of that as a part of a community living policy as well.
Huge problem in a population also very confounded with those 6 disability questions. Natalie?
I'll add another layer to this delicious cake. There's a lot that would be really helpful. I think one thing in particular that would be interesting to have is good data on the Money Follows the Person program, broken down by demographics, unmasking managed care issues that hide what's really happening in states. This program, it's not serving older adults as well as it could, and we really need to figure out why and what are those barriers, and then other populations specifically. We don't know much detail, but I'm sure there are specific populations that it's not serving as well as it could. So, finding out more, helping people transition back to the community from institutions is a super important goal, and we need to learn more about how to help them.
Ari mentioned the NHIS, so I got to say it's been 30 years since the disability supplement. It would be nice to have another go round at that extensive data set. All right, I think we're going to go to our audience questions now. And our first, what's an example of a good research question that would capture the impact of COVID-19 on community living individuals in both the short term and long term? We're looking to add this to an existing survey of Money Follows the Person participants. That's a tough one.
I can just share my answer to that question, and that would be I don't think that there's a single question. You probably have to get at it with a few questions, and there have been quite a few studies that have looked at the effect of COVID on persons with disabilities broadly, as well as by specific population groups. So I think several of us on this panel could steer you towards some of the articles that have been written and the questions that were embedded in the surveys used for those articles. But that's where I would go to get it, would be some of the more recent research that's already been done.
I'd be very interested to know, and I think this probably would make sense alongside other questions, to what extent COVID restrictions on visitation limited access to MFP staff, and to what extent there was change in people's ability during COVID to make contact with people who can support them to leave nursing homes and other institutions. Visitation restrictions likely played some role there. The fact that there were, some waiving of the regular assessment requirements, including MDS, parts of MDS and PASSAR during that time period likely played some role there. It would just be interesting to try and document that empirically. I'm not exactly sure what form that question would take, but that would be an area that I would find interesting.
This is Silvia, and I think that is a difficult one to answer in one question. I guess I'd be curious about how individuals with disabilities feel COVID-19 has impacted their safety in the community, their capacity to stay in the community, and I'd put that along dimensions of the ability to get health care, ability to perform, to go out and do errands, chores, life chores, complex activities of daily living, and to stay mentally healthy. Of course, I'm giving dimensions of it, but this sense of being able to survive in the community is what I guess I try to get at.
Yeah, I'll just add two more sort of aspects to that. I think social isolation and family caregivers and unpaid caregiving changes, and that if people had people at home that they could rely on, if those people had to isolate themselves because they were working in the community. Lots of questions.
An AI related question. Curious on the panelists' thoughts on how AI might be useful in crowdsourcing both participant and family perspectives on needs and service efficacy.
I'm not sure that that's necessarily a use case for AI. I think that would probably just be an area where we would want to survey families and people with disabilities. I guess the only kind of fancy technical thing I could see potentially being useful there is maybe you could use like natural language processing to, quickly pull information from, text submission or people writing about their experiences and try and quickly identify common themes. But I honestly think that the big thing we need in order to get family and self-advocate perspectives to a greater degree is to just ask people on a more regular basis. There are a lot of data collection. It's a lot of data collection oriented towards older adults, and we have really high quality longitudinal data collection for older adults that lets us follow people over time, like the Health and Retirement Study and NHATS. We don't really have anything comparable from a longitudinal perspective for younger people with disabilities, younger LTSS users. So this may be one of those instances, as you could hear, I'm kind of AI positive, but this may be one of those instances where the more straightforward and less technically complex method may make more sense.
This is Silvia, and I given what we know about some of the barriers that various people with various disabilities have when it comes to use of technology, both access to the internet and actual devices, I'm not sure that it would be the best tool to. I'm just trying to. I'm just saying I agree with Ari that I think that using AI might overlook some individuals who wouldn't typically interact with AI or even online. but it does make me, the question made me wonder about the capacity to get an unvarnished look at what the general public knows, feels, understands about living in the community with disabilities, because I suppose there could be a way to potentially gather some of that, all that exists out there on the internet. I'm kind of thinking that a lot of it will be ugly. It's not that the general public often has unvarnished and unpleasant opinions about people with disabilities. And I suppose you could use that to establish that, yes, it's true. It really is unvarnished and ugly.
Got about 4 minutes left. I'm going to sneak in one final question, and maybe a couple of you can comment on briefly. A few comments in the chat about guardianship, and we haven't really talked about that in a research context. And there are concerns expressed here about Olmstead violations around guardianship in particular, and where people are living or may not have a choice in living in congregate settings. What do we know about guardianship from a research standpoint, and what do we need to know?
As an advocate, I think, addressing guardianship and trying to get people with disabilities out of guardianship or divert people from going into guardianship is tremendously important. It's, often the first on-ramp into institutionalization, sheltered workshop placement, any number of other outcomes that we see as incredibly concerning. As a researcher, I just think we don't have a lot of data, and it's a huge problem, right? Guardianship is handled usually by the state court system. And so, there isn't standardized data collection across states. I know there are a lot of folks working to address that, though. And Amy, moment I said we don't have a lot of data, your hand shot up. So please correct my my mistaken assumption there, if that is the case.
Amy, we've got about 45 seconds for you.
Okay, 45 seconds. I just was going to take kind of the opposite side of guardianship to, as a field, we've embraced supported decision making, but we have no research really of any quantity or quality that tells us how to do it, what the effective ways to teach people about supported decision making at the individual level, the family level, the systems level, the courts. So there's just so much research that needs to happen around how do we make supported decision making work for people. We have a lot of anecdotal information, a lot of stories, and there's big pushes in states to move in that direction, but we need research data.
All right, we're going to have to leave it there. I want to thank all of our panelists for a robust and very interesting conversation. Lots of ideas about where to go in both the realm of research and policy and practice. So Sid, I will turn it back to you.
Thanks so much, John. And again, thank you to all the panelists. Thank you for the audience and their active contribution to the chat. I just wanted to do kind of like a final, please join us for our final session in the State of the Science next Tuesday. Please do share your recommendations for future research. And the CLPC will be releasing a report later this summer with findings. We also have a special issue out of the Disability and Health Journal. Submissions are open till September 1st. So if you have research ideas on this topic, we'd love to see them. And again, thank you all, and definitely stay tuned to the CLPC and the Equity Centers. We will continue to have some great offerings coming. So have a great weekend, everyone, and see you soon.
Hi, everyone.